Hi there, welcome to Ask the Chiropractor, your source for ultimate health, healing, chiropractic, and medical related information. I'm Dr. Adam Rodnick, a chiropractor out of Commerce Township, and I'll be your host today. We have two special guests with us today. We have Dr. Colin O'Keefe and Dr. Rachel O'Keefe.
Thanks for having us.
Absolutely, welcome. So Dr. Colin is an orthopedic surgeon and Dr. Rachel is an OBGYN. So I want to start off talking with you guys a little bit about what it means to be a specialist in medicine. So let's say someone has a problem and they go to, let's say, their regular doctor. What does it mean different for someone to go to their regular doctor compared to an orthopedist?
I think it's all based on your training. When you get into medical school, there's a lot of different ways to go. Most medical schools have a pretty rigorous 4-year curriculum where you have to fulfill certain requirements. And then there are points at which that you get to do elective rotations in medical school. And that's when people kind of find what they like to do. There are primary care fields like internal medicine, family practice, pediatrics. There are some more specialized fields that involve surgery, and it just depends on what you're interested in. And those tend to be the things that people end up working towards. And basically there's an application process after you finish your medical training. And then each field has its own set of standards as it relates to credentialing and becoming good in the field. So for orthopedic surgery, for example, I did 4 years of medical school, and then the orthopedic surgery residency is 5 years. We learn, you start from doing very basic things, taking history and physical and examining patients, and then working up to basic fracture care, doing casts, manipulations of fractures. And then you start doing subspecialty training, surgical training, under the care of what we call an attending physician, as someone who's passed all the steps in their training, and they essentially supervise your training. So, for example, every field has a little bit different path. Primary doctors tend to know a lot, and they often, depending on what is going on with the patient, what kind of health problems that they're having, they may refer to somebody who has specific training in one of these different fields.
And then how about yourself, Rachel? What's the path to get into obstetrics and gynecology?
So for me, I completed my medical school at Michigan State University College of Osteopathic Medicine. I graduated in 2009, like Colin. I went on and completed an obstetrics and gynecology residency at McLaren Macomb in Mount Clemens. That was 4 years of training, and I've been in private practice at Walnut Lake OBGYN now, going on 4 years there as well. As an OBGYN, some patients like to use us as their primary care physician, which is great, and we're happy to serve as their primary care physician as well. But I do have specialty training in obstetrics. We take care of the pregnant patient, we deliver their babies, perform C-sections, take care of them postpartum, and then of course the gynecology component as well, specializing in women's health. Take care of a lot of patients with bleeding dysfunction, do a lot of contraception management, and then of course performing surgery as well. Minimally invasive surgery is one of my specialties, robotic surgery, vaginal surgery, ablations, and things like that.
So what percentage of your time would you say is spent in the office compared to in the hospital doing deliveries and such?
Mm-hmm. So I think probably 75% of my time is spent in the office. We're in the office most days a week seeing our patients. We also perform in-office procedures, and then the remainder of my time would be spent on call at the hospital, managing laboring patients, doing deliveries, and performing surgeries.
Gotcha. And how about yourself, Doc? Would you say most of the time in the office, most of the time doing procedures and surgeries, or split?
Yeah, so I've been in practice 2 years now. And it takes most orthopedic surgeons probably even up to 5 years to build a very busy practice. At this point, I probably spend 60% of my time in the office, seeing patients, doing new evaluations, seeing follow-up patients. And the other 40% of my time will be spent performing surgeries. And we have a few different facilities that we work out of. We're on staff at multiple hospitals around the area, and we also work out of a couple of outpatient surgery centers. And we stay pretty busy, so we like to make things convenient for our patients and try to work around where they live and where they're coming to see us from.
One thing I really like about your practice and your group is that you have multiple orthopedic surgeons, but you guys also do quite a bit of imaging in the office, and you also have an emphasis a lot of times I notice on starting conservatively. You have your own physical therapy department, and before surgery a lot of times you'll encourage patients to start conservatively with things like chiropractic care, things like physical therapy, injections, things like that before surgery.
Yeah, that's right. We kind of pride ourselves on providing all options for patients. We treat pretty much all body parts. So we see a lot of people, and the good news is the majority of patients that we see do not need surgery, or at least don't need any sort of urgent or emergent type of surgical procedures. When we're on call and we see a bad fracture, that's kind of a different story, and a lot of people will need a surgery at the time that they're in the hospital. But the vast majority of our patients come. We see a lot of patients with shoulder and knee pain, and also hip, ankle. Like I said, we run pretty much top to bottom. Most patients will do very well with trials of conservative management. That includes physical therapy, chiropractic care, certain types of medications, injections, and we're able to take care of a lot of different problems simply by taking a good history, doing a nice physical exam, and treating patients very conservatively. And we have really good outcomes. I feel like like you said, we have a physical therapy location in our office. We really like our therapists there. That's why they're there, and they tend to have very good results. We also have a device called the MLS laser. It has been shown to reduce pain and reduce inflammation. It's a good tool that we use, and a story I like to tell our patients is that part of my training, I did an extra year training called a fellowship. So that helped me subspecialize in what we consider sports surgeries, which are a lot of minimally invasive procedures that we do through the scope and the small camera. And that part of my training was spent with the Tigers, the Red Wings, and the Pistons, so 3 of the local sports teams. All of those teams had this laser device in their training room. So usually if somebody's getting paid millions of dollars to do a job and they're using these types of things, they tend to have pretty good outcomes. So, and I think it's a good tool.
And if they know, someone's in trouble, right?
Right, exactly. It's too much money to be spending on those guys that are getting paid all those bucks.
So, and I like that we can use you guys for our chiropractic practice as a really good asset that a lot of times in general with patients, I'm kind of the front line. A lot of times people either go to their primary care or they see us as a chiropractor as the first step if they have an injury, a problem, and if there's something that we can help conservatively, we obviously want to take care of them right here in our office. But a lot of times we may send it out for a second opinion, for some different imaging. You guys work with ultrasound or MRIs. We order a lot of MRIs as well, but a lot of times we'll send to you guys for second opinions, especially for different work with extremities, shoulders, knees,
Right.
hips, different injuries.
Right. Our practice specifically, being orthopedics, is a very referral-heavy practice. A lot of people are set up with a primary care doctor or internal medicine or family doctor who they've been seeing for a long time, and that's kind of their doctor who's in charge and who helps them with figuring out various aspects of their health. We rely on referrals for our practice. I mean, occasionally people will find us on the internet and they'll look us up and like what we do, but we still rely on a lot of referrals, and it's good to have good relationships in the area.
Absolutely. Most people don't start with looking up
Right.
orthopedic surgeons.
Right.
They want to go to their doctor, their chiropractor, and get their opinion. So
Right.
not too many people just call out of the blue.
No, it's pretty rare. Most people are getting advice from friends, family, other doctors, and that's why we like to build good relationships in the area and have a nice referral base. It kind of helps us, it helps us keep a busy practice, but it also helps with reciprocal referrals. So we know if we get a patient who's coming to see us for a shoulder problem, for example, and it may be more related to their neck, we have some good chiropractors that we know that we like to refer to.
That's right.
Yeah.
Let's. We have a little image we want to show about the shoulder, and we'll put it up in the background so we can take a look at that. And so I know one common buzzword that I'll hear a lot of people say is just the word rotator cuff, right? And I'll hear people come in and say, "Doc, I think I have a problem with the rotator cuff of my knee or the rotator cuff of my elbow." So let's explain to our audience what the
Sure.
rotator cuff is.
So the rotator cuff is specific to the shoulder. There are actually a series of 4 muscles that start in the shoulder blade. Those muscles turn into tendons, and those tendons attach on the bone. I think it looks like we... No, no pictures yet, but
So it's 4 muscles.
4 muscles, correct. They all start on the shoulder blade. There's a muscle that comes right across the front part of the shoulder called the subscapularis. It's the front muscle in the rotator cuff. It actually sits on the front part of the shoulder blade. It's kind of hard to visualize, but it's between the shoulder blade and the rib cage. The other 3 muscles are the supraspinatus, the infraspinatus, and all the way pretty far to the back on the shoulder blade is the teres minor. Those 4 muscles are very important for a normal functioning shoulder. It's very common for people to develop tears and one or more of those tendons through injury, through the aging process. There's some other types of systemic body diseases like rheumatoid arthritis that commonly have rotator cuff tears associated with them.
And would you say supraspinatus is usually the most common that you repair and the most common that you see torn?
That's right. That's basically the muscle that's the most on top. The supraspinatus help keep the ball inside of the cup. So if the ball in the cup looked like this, the supraspinatus is kind of the roof of the shoulder joint. It's a very commonly injured tendon. Like you said, the most commonly injured tendon in that part of the shoulder. And it's very common for us to treat those, non-operatively and surgically.
And like you said, the difference sometimes between a shoulder problem and a neck problem sometimes can be slight as far as the symptoms go. So supraspinatus is the muscle that allows us to go like this, what we call abduction. And so a lot of times if someone has a radicular problem or a problem in the cervical spine, these are the nerves at the bottom of the neck that go down the arms. So if they have a herniated disc, a bulging disc, they have spinal stenosis, they have subluxation, or they have just irritation to the nerve roots themselves, they're going to have a radicular complaint, meaning it's radiating or going down the arm. So they may have trouble lifting their arm, they may have pain into the shoulder, down the arm, so they may think they have a shoulder problem. So it's important to take good examination, good diagnostics. We have something in our office that's a digital motion x-ray, so we can take a video x-ray of a cervical spine. It helps us determine if there's problems in the bottom of the cervical spine with the individual motion of the joints. And so if we determine it's a cervical problem and we see results with it, a lot of times we'll see changes with the shoulder, with the arms, and a lot of times we determine that it's not a cervical problem, it is a rotator cuff tear, and that's one right away we want to make sure to send out to someone like yourself.
Right. The thing that we notice probably most often is the biggest red flag for us that it's a neck problem versus a shoulder problem is it's very rare to have pain past the elbow as it relates to a shoulder problem. The nerves in the shoulder are just not wired that way. Typically, if people have a pain that starts in the shoulder and goes all the way down their arm, they more commonly have a pinched nerve in their neck, like we use. Especially
the numbness and tingling in their fingertips. Yeah. We see a lot of people come in and complain about, talk about that.
Exactly, and doing a very focused, specific exam will often help us figure out which nerves we think are involved. And that's one of the things that we do see quite often. People think it's the shoulder, and it turns out it's the neck. And we kind of pride ourselves on doing good physical exams in our office and helping to figure out what we think is the actual problem.
Absolutely. You guys take X-rays and radiology right in the office as well, as
yeah,
well as
right.
ultrasounds, right?
Yep. We have our own X-ray suite within the office. And the issue with the rotator cuff, if we think it's a specific rotator cuff problem, is that muscles and tendons are made up of mostly water, so the X-ray beams tend to shoot right through them. We can find hints of problems with the bones on the X-ray, and we can see arthritis in the X-ray. That's really the standard for looking for arthritis. But the problem becomes if we think it's a tendon injury. We have ultrasound machines in our office that allow us to look directly at the tendons, at the muscles themselves, and that can give us more information about whether or not we think there's a tendon involved.
And then we send out for MRIs as well, obviously to look at
That's right.
soft tissue. And we do the same thing with the spine. We look at our X-rays for bones and alignment issues, but if we think there's maybe a problem with the disc or the cord, a lot of times we'll send for an MRI as well. And something I pride myself on is we always like to, when we get the MRI results, not only review with the patient, but show them on the images. We want them to understand and to see exactly what's going on with them. And so let's talk a little bit about some orthopedic issues during pregnancy, perhaps, too. We take care of a lot of women in our office during pregnancy, and we see a lot of women with sciatica. And that's another one I'll hear patients say, Doc, I think I have sciatica in my shoulder or some sciatica in my knee. Right. And so let's talk about how pregnancy could increase symptoms of sciatica and what that is, mm-hmm. and also some other particular issues that women may have during their pregnancy.
Mm-hmm. So with our pregnant patients, musculoskeletal discomfort is a very common complaint. The majority of patients that I will see throughout their pregnancy will complain of musculoskeletal discomfort. Sciatica is a very common complaint. Other common complaints that we'll hear of will be lower back pain, rib pain, pelvic pain and pressure, pain in the pubic symphysis. Also, carpal tunnel is another common complaint that we'll hear in the office. For our patients, we do like to work together with either physical therapists and chiropractors to help improve the structure and the function of our patients during pregnancy, to improve their range of motion, improve their pain, optimize their structure, again, to improve their symptoms.
So let me explain to our audience what that term sciatica means and why, a couple of reasons why that would be increased with pregnancy. So these bottom couple of lumbar nerve roots, they come down and they form what's called the sciatic nerve. That's the nerve that runs down the back of the leg. So a lot of times I'll hear people that may have back pain say, oh, I have sciatica here. Well, that's not sciatica. Sciatica is a symptom, not a condition. It's a symptom where there's pain or numbness radiating down the back of the leg where the sciatic nerve distributes. And so one reason we see a lot more in pregnancy, obviously, is as the baby starts to develop, the uterus gets bigger and the belly kind of sticks out, and so it just puts more pressure on that lumbar spine. It causes the spine to increase its flexion here and causes more irritation, pinching to the lumbar nerve roots, which then goes down the sciatic nerve. So we actually take care of a lot of women in our office during pregnancy, and that's one question I'll get all the time is, Doc, is it safe to work on me while I'm pregnant? Mm-hmm. And that's something we see in our office every day, and I always want to ensure people that it's absolutely very safe. And how protected is the baby in the womb? Mm-hmm.
Yes, no, I agree. I refer many patients to a chiropractor for manipulation. And again, sciatica is a very common complaint that we do see. It's very safe to receive chiropractic care while you're pregnant. Of course, just be straightforward with your chiropractor regarding your issues. If you're having any complications during the pregnancy, that would be a contraindication to chiropractic care, then of course we think of other ways that we could treat the patient. But again, the baby is very protected, and seeing a chiropractor would be safe and indicated.
And we always want to, if we notice anything too, we always want to make sure they report that right back to their physician, to their OBGYN. And so communication is really important in general. I see that between multi-specialties for sure. And so a lot of times it's hard to get a hold of, certain doctors or the doctor in general. I tell my staff, they call your staff, they leave a message. So a lot of times sending faxes, sending emails, if doctors know each other, it's really important. I'll find myself a lot of times with some of the specialists that we refer to, just sending a text message, sending Mrs. Jones and this is what's going on with her. And we'll still send our full report, we'll still read our full report, but just a simple blurb can sometimes really save some time and effort with communication between specialties. Mm-hmm. We see that quite a bit. And another thing I'll see with a lot of women during pregnancy is specifically after the pregnancy. I'll see a lot of times women will have maybe a more back pain after the pregnancy or more pelvic pain after, because near the end of the pregnancy when they're secreting oxytocin and relaxin, these are smooth muscle contractors that will allow the baby to come out. But the reason why a lot of times women's feet may swell as well, it relaxes some of the ligaments in the feet so they kind of expand. But same thing happens with the pelvic girdle, and a lot of times there'll be pelvic floor and pelvic girdle problems where it just didn't set back in just right after the pregnancy. So we'll see a lot of times where women will need physical therapy, or we'll do chiropractic adjustments with them after the baby was delivered. Mm-hmm. So let's move on and talk a little bit about some common things we see with the knee joint. I know we have another image we'll put up in the background while we talk about it. And so what are some of the most common things you see with knees?
I would say the two most common knee problems that we see are arthritis. And what arthritis is all the joints in your body, there's typically two bones associated with a joint, with some exceptions where there's more, but the ends of your bones are coated with cartilage. And that cartilage is a very soft, kind of slippery substance. There's actually a statistic about how slippery it is, and if you put two pieces of ice and you rub them together, your cartilage is actually 100 times more slippery than that.
100 times?
Yeah, so it's the articular cartilage in the joints is very essential to have normal motion in your joints. The arthritis process is the wearing away of that normal cartilage in the joint. There are multiple stages of that. which involve just kind of some wear and tear and softening of the cartilage, and it goes all the way up to where your cartilage is gone, and then you have what we call bone-on-bone arthritis, and that's a pretty commonly used term. And when people talk about bone-on-bone arthritis, what happens is that the cartilage is all gone, and on both sides of the joint you have bones touching each other. And that's not a problem in and of itself, but it's very painful. You basically get enzymes released into the joint, and that lining around the joint sucks up those enzymes and tells your joint that it's sore and it hurts because the cartilage is gone.
We see something very similar in the spine as well, because in between each vertebrae we have these little shock absorbers called intervertebral discs, or IVDs. And the same thing there. Over time, whether it's from trauma, from poor misalignment, from wear and tear, from congenital abnormality, they can start to wear out, kind of like a sponge. You know, if you took a wet, pliable sponge and squeeze it a few times, it's easily going to poof back up, but a dried up, wrinkled up one wouldn't. So the discs, they don't get good, healthy motion anymore. They start to dry up, and eventually, just like you said, we see bone on bone.
Right.
And so the digital motion x-rays we take in the office can really see where the bones are kind of grinding on one another, and that can cause a lot of significant symptoms, pain, but can also in spine affect the neurology as well. And then, so arthritis you see for mostly seniors, obviously.
Yeah, there are some young people who develop arthritis. You know, there seems to be a trend, it's been kind of ongoing for the last number of years, that people are staying more active. Younger people seem to be more active, and people are staying more active into later years. We actually do see a lot of arthritis in people who are younger now. We see arthritis in people who are a little bit heavier. There's multiple factors that cause arthritis. One is just an aging process. Another would be the amount of weight that you carry around.
Nutritional deficiencies.
Nutritional deficiencies, and people are just genetically predisposed to having certain types of arthritis. Very common, and there's a lot of different ways that we treat that. Physical therapy is very important because of the fact that patients often lose muscle mass in their thigh muscles. And those thigh muscles, the quadriceps muscles, are very important for vital functioning of your knee itself. We also can do things like medication. We typically recommend anti-inflammatory medications. We sometimes do cortisone injections. What cortisone is a powerful medication that will help reduce the inflammatory process inside of the knee. There's another kind of injection that's called viscosupplementation, which is kind of the long generic name for it. We tend to call them gel shots. And what these gel shots are, it's like a vitamin supplement for the cartilage that's in your knee. It also produces an anti-inflammatory effect. And then sometimes when people don't respond to those things, we talk about different types of surgery procedures that we can do. And ultimately, if they don't get better doing anything, then we talk about knee replacement surgery. So arthritis is very common, and it's something that we see multiple times a day.
In every joint, every age group,
exactly,
all over the board.
Yeah, arthritis is extremely common. There's a few areas that's more common than others. The knee and the hip are usually the most common, but people will often come and they'll have bumps in their fingers, and getting arthritis in your hands and fingers is also extremely common. It's just not as bothersome because you don't walk on your hands.
We see people in their late teens, 20s and 30s with arthritis in their spine already. We see very early signs of it, not significant arthritis,
right, but
we'll see osteophytic formation or some bone spurring, and people in their 20s regularly. Now, Dr. Rachel, when would you say is the ideal time? And I know a lot of people may not start early enough when they find out they're pregnant with care.
Mm-hmm. So ideally, even conceptually, it would be great if patients were in optimal health and physical condition. A lot of people have pre-existing conditions prior to pregnancy, so establishing care, with their primary care physician, or if they have an established relationship with a therapist or a chiropractor, ideally at the beginning of their pregnancy would be fine. So in pregnancy, as you mentioned earlier, you're producing more hormones that allow your ligaments to be more relaxed, to accommodate your growing belly, your growing baby, and your pelvis. Throughout the pregnancy, as your baby is growing, a lot of the pre-existing aches and pains can worsen. So it would be great if right from the beginning we were all working together to optimize the patient's conditions.
Do you see some people that may not have prenatal care until they're 2, 3, 4 months into pregnancy before they come to see you for initial workup?
Yeah, occasionally
not
we
that
do.
often.
Yeah,
Certain areas more than other maybe.
Typically, we'll see patients for their first visit when they're about 8 weeks along. If patients have a positive pregnancy test at home and they're concerned, of course, we would always see them sooner than the 8-week mark. But if they're doing well, we typically will see the patients at 8 weeks. They'll have an initial ultrasound, their initial visit where we'll do their new OB education, review very basic things like nutrition, genetic testing, kind of what to expect as they progress throughout the pregnancy. And then we'll be seeing the patients every 4 weeks until they're about 28 weeks, and then we see the patients every 2 weeks. And then at 36 weeks, we see the patients weekly until they go into labor. So, most often we are seeing our patients at around the 8-week mark, but sometimes we'll see them later.
Gotcha. And then I know another thing that we see in our office pretty commonly is we'll see a lot of children, babies that may have torticollis. And so would you say that maybe women that have a retroverted uterus or certain complications, maybe with multiples, the babies are more likely to come out with a little bit of kink in their neck, basically, which is the sternocleidomastoid muscle can be really tight and pulling on one side?
Yes, it's definitely a possibility.
So we see that quite a bit in our office with children. And what are a few other things that you guys you watch out for, you look for? Explain maybe what preeclampsia is to our audience.
So throughout the pregnancy, we're always monitoring our pregnants for any problems with hypertension or preeclampsia throughout their pregnancy, gestational diabetes, preterm labor, things of that nature. Throughout pregnancy, with preeclampsia, it's a problem where patients are having elevated blood pressure and protein in their urine. It's also more of a widespread systemic disease when it becomes more severe. So we're always reminding our patients about the signs and symptoms of preeclampsia and monitoring them for that.
Awesome. Well, thank you guys both for joining us. That's about all the time we have today. Again, this is Dr. Colin O'Keefe from Letterman Cordowitz Orthopedic Group in West Bloomfield. Dr. Rachel O'Keefe, Walnut OBGYN, also in the Lakes Medical Building in West Bloomfield. And I'm Dr. Adam Rodnick, chiropractor at Rodnick Chiropractic in Commerce Township. And we'll see you next time on Ask the Chiropractor. Stay healthy.